Shingles A to Z. We are all familiar with shingles, but I'm going to take you through all the necessary facts about the disease called shingles. Without further ado, let's go. Let's review certain pieces of information before diving deeper into shingles. Without chickenpox in your life history, you can never have shingles, meaning no chickenpox in the past, then no shingles ever in your life. But you may have chickenpox and you may never come down with shingles for the rest of your life. You can transmit chickenpox, but you cannot transmit shingles directly. There are some presentations already published by me about shingles. We are going to find some of them right here. But everything is all about shingles. You are familiar with the term that shingles will affect only one dermatome. Right here, you will find out how it can affect more than one dermatome. You've been told that it will not cross the mainline, but you also know right here that it may cross the mainline. You are familiar with the fact that you will identify shingles with painful rash. Yeah, that is externally, right? But you will find out right here that shingles could be internal. So, let's quickly touch on disseminated shingles. This is pretty rare. Here, the rash will be found in more than one dermatome. The rash will not be limited to one part of the body. It can cross the midline. As a matter of fact, in disseminated shingles, it will cross midline. In disseminated shingles, it is associated with profound decrease in immunity and is going to be involving more than 20 blisters in more than one dermatome. That is disseminated shingles. So, to those who would have known that shingles is simply defined as rash and pain limited to one dermatome and that will never cross the midline, then you can have a rethink. The entire presentation is all about the virus because shingles is caused not by bacteria, not by fungus, it is caused by virus. By way of definition, shingles is a viral infection. Initially, it will be from varicella zoster virus that is responsible for chickenpox. Then, after chickenpox, the virus will undergo latency period in the ganglia. Then, under certain conditions, it will be reactivated and will come down with shingles as herpes zoster virus. In addition to the pain, the rash, the fever, later on the individual can come down with some complications, topmost among which will be post-herpetic neuralgia. Let's examine the pattern. This is from herpes viruses that are affecting both animals and humans. About 5 scores of these viruses are found to be affecting both animals and human beings, but only 8 will be infecting humans frequently, and amongst them will be varicella zoster virus that is responsible for chickenpox and shingles. Others will include the following: cytomegalovirus, herpes simplex, Epstein-Barr, Kaposi sarcoma, and the rest. Now, the 8 herpes viruses affecting human beings are further classified into alpha, beta, or gamma. as found here. And varicella zoster virus is found among the alpha group. Alpha herpes viruses will include simplex virus, varicella zoster, or herpes zoster. They have a short cycle for replication, and they have large host range. When there's chickenpox, mostly during childhood, but anyone could have chickenpox. Why that? You will know in a bit. The incidence of chickenpox is dropping thanks to vaccination, and it is common in winter to early spring in temperate countries. Chickenpox today means that you are at the risk of having shingles later in life, but you cannot have shingles without prior history of chickenpox in your life. One attack of chickenpox is expected to confer live immunity, but second episode of chickenpox is a possibility if the first attack of chickenpox was too mild to build enough immunity against the same varicella zoster virus. So, it's not everyone who had chickenpox as a child that may not have chickenpox again as an adult. You can still have it if the first episode was too mild to build enough immunity against it. Still on part two, if someone should ask, is shingles contagious? And a physician tells you no, and another one tells you yes, they are both right. Let me explain. The person who said no is trying to tell you that shingles that is caused by herpes zoster virus itself is not transmissible to another person and cause disease called shingles, because you must have chickenpox that will be reactivated before causing shingles. The other physician who says yes is also right, because once the rash is formed with blister, you can transmit varicella zoster virus to non-immune individual against chickenpox, or someone who had chickenpox in the past but had not developed enough immunity against it. You have shingles today, you have blisters, you can transmit chickenpox to such individual. It could be airborne when the vesicle containing fluid or respiratory secretions is found in the air. Then, possibility of direct contact with active lesions containing blisters or swimming in pools infected with varicella zoster virus is another possibility. Could it be through droplets? Yes, but that is pretty rare. Droplets, that is rare, is possible in disseminated shingles and in overcrowded places. You can only transmit varicella zoster virus responsible for chickenpox. You cannot transmit shingles to your neighbor directly. If you have shingles and someone near you has no previous chickenpox history, he or she can come down with chickenpox today. If you have someone around you without history of vaccination, he or she can pick varicella zoster virus from you with shingles today. But if the lesions are dried or crusted, then you cannot transmit the virus to your neighbor. The saliva of affected individuals have been found to contain the DNA of varicella zoster virus, but I am not stating categorically that you can transmit shingles via saliva. We've been talking about chickenpox. Okay, let's now see how chickenpox could be transmitted. It is caused by varicella zoster virus. Yes, through airborne or direct contact with open blisters, you can transmit chickenpox to people around you. Either from a person with chickenpox or shingles, you can pick varicella zoster virus. The host airborne or droplet from infected person is possible in that individual even before rash will appear, and that will happen as late as 2 days before the rash will appear. Let me explain here. Either someone has shingles or a child with chickenpox or an adult with chickenpox, you can transmit it to people around you, either airborne or droplets, when they are in contact with you, even before knowing or before being fully diagnosed that you have shingles. And that can happen as 2 days before the rash will appear. And once the neighbor had picked the virus through nasopharyngeal lymphoid tissue, it will get into the circulatory system. The battle with the host immunity will ensue between the varicella zoster virus in T lymphocytes for about 2 weeks before rash will appear in the new host. Then the varicella zoster virus will be present in the blood at about a week before the rash could be seen. Then the level will drop in the blood at about 2 days after the rash had appeared. I have mentioned latency before. Let me now shed more light on that. It is only about the fact that a child would have developed chickenpox early in life, or an adult who had not been exposed to chickenpox before, or who had been exposed to chickenpox but hadn't built enough immunity, can come down with chickenpox. Either as a child or an adult, the chickenpox will be resolved. Great. Remember, we're dealing with latency, right? We cannot see the rash anymore. Pain, anything disappeared. No fever or anything. But the virus is not going anywhere. The virus is hiding. Will now undergo latency in the regional ganglia, in the dorsal root ganglia, neurons of cranial nerve, autonomic ganglia, and will remain quiet in latency phase for as long as the individual lives, with the help of the host defense department. Interferon, cellular and humoral immunity will be working against the varicella zoster virus to stop the virus and prevent herpes zoster virus from gaining ground to form shingles. Okay, we've now gone through what will happen during latency. But under certain conditions, which I will go into in a bit, the host immunity could be overpowered and the virus will gain ground. Then the strain comes to the virus again. We can then say reactivation has occurred and we are down with shingles. It can spread within the ganglia where the latency are taking place and can spread to many sensory nerves. Through the sensory nerve, it can affect the skin, giving us the rash that will be itchy and painful. Inflammation will continue to go on and leading to nerve damage. And we are down with neuropathic pain. An example will be post-herpetic neuralgia. When it comes to the epidemiology, shingles is worldwide and millions of people are affected. Everyone is familiar with the word shingles, or at least you are familiar with chickenpox. Now you know. When you have chickenpox, okay, as you get older, you can come down with shingles. Okay. Incidence increases with age. People less than 50 years old, less people will have shingles. But when we become older, greater than 80 years, more of the people in this age group will have shingles. The incidence is increasing globally because maybe more record is being kept and people are getting older and they had shingles now because they had chickenpox when they were younger. 25 to 30% were shingles amongst everyone who had chickenpox. Pretty low, but you can ask the people affected because when you look at this figure, you say, well, 75% or 70% will not have shingles. Oh, that's fine. But ask those few ones affected. It's pretty painful. Vaccination is helping us. Why that? It's now delaying the onset and severity of shingles. So we are now picking shingles only in the elderly because of vaccination. And for reasons not clear to me, more females are affected than males. Still on epidemiology, let me touch on disseminated shingles again, because some of us would have crammed some facts that shingles will not cross midline, it's limited to one dermatome, ipsilateral, and so on. In disseminated shingles, it will cross the midline. It will be more than one dermatome. But it is rare and found in overwhelming immunocompromised state, like HIV or cancer patients on chemotherapy. There are certain complications that will be so severe here, post-herpetic neuralgia, and of course, it will affect the eye, giving us epizoster ophthalmicus. It is highly contagious. Remember, shingles can pass chickenpox, but cannot pass shingles to anyone directly. The common risk factor, either in disseminated shingles or not, will remain chickenpox history. Now, let's consider the risk factors. Coincidentally, I can group the risk factors into three. The positive history of chickenpox in this individual, the age, and the immune status. Now, let's break it down. Reactivation is a factor of, number one, the age. The older you become, the more the likelihood of coming down with shingles if you had chickenpox prior. And the more the severity, including the probability of hospitalization due to shingles. and the complications will be getting more and more severe. Post-hepatic neuralgia, like an example of complication, is twice or triple in individuals greater than 50 years old compared to those who are younger. While post-hepatic neuralgia will likely be 40 to 50% in anyone greater than 80 years old. In other words, when you are aging, you are likely going to have the varicella zoster virus reactivated, giving you shingles and making the probability of post-hepatic neuralgia more likely. Another risk factor is decreased immunity. When you get older, you know what will happen, right? You have HIV or you have hematopoietic cell transplantation, or you're on certain medications, either chemotherapy or disease-modifying anti-rheumatic drugs, all this, or there's poverty with lack of good food, or you are battling with debilitating diseases, including stress. The immunity could drop, and varicella zoster virus could be reactivated. You're down with herpes zoster virus, giving us shingles. Still on risk factors, when it comes to gender, more females will be affected than males. I don't know why. When it comes to the race, it is found in United States that non-Hispanic whites will be affected more than blacks in US. Physical trauma could add to the probability, and certain comorbid conditions could make it more possible that varicella zoster virus in latency phase could become reactivated. For example, in autoimmune diseases and chronic lung disease and kidney diseases and even depression. With all these autoimmune diseases, my understanding is the medications you are taking to suppress the autoimmune condition will likely lead to reactivation of varicella zoster virus, giving us shingles. And when you are depressed, it will affect everything, including diet and other things to do, leading to decrease in immunity. Now, we're about crossing to another territory, and that will be pieces of information on pre-hepatic neuralgia or pre-eruptive pain. That is, we've not seen the rash yet, but the person is having pain due to shingles. Let's go. Pre-hepatic neuralgia. Pre-hepatic neuralgia. This is not post-hepatic neuralgia. Without further ado, let's go. Neuralgia means nerve pain. Hepatic, in this case, herpes zoster virus. Pre means before. So, we are talking about before the full appearance of signs and symptoms of herpes zoster virus, we have nerve pain. Why this presentation? It is necessary because we run into wrong diagnosis with pre-hepatic neuralgia. Is going to present in such a way that the patient will be having localized pain. Many investigations would have been done. Time and money would have been wasted. The patient will continue to suffer. Yet, no definitive diagnosis. Results are coming back after CT scan, cardiac enzyme assay, ultrasound, X-ray, everything is coming back negative, yet no resolution. We're not going to blame anyone for making wrong diagnosis here, but this presentation will be helpful because no rashes yet. However, simple history of past chicken pox in this man or woman in the past, maybe when he or she was a child, will help, will give us the clue. Because no more rashes for many years. And today, at the clinic or emergency room, no rashes. But he or she is having localized pain. Sometimes it could be diffused. The pain will be in a particular dermata. It could be regional. Still on clinical features, the pain might be mild. Many times could be severe. There might be other associated symptoms like headache, fever, malaise, fatigue, and so on. Days after, we might pick rashes, but we may not. And when we pick rashes, it might not be localized to where he or she is having pain. The rashes can occur in other parts of the body. If we don't have rashes at all, that's another definition. When we see the rashes, we then know, oh, this is herpes zoster virus. After the history of chickenpox, right? Okay, we are dealing with shingles. But before we were able to pick rashes, we've made the wrong diagnosis, and we're not faulting anyone for that. Because when this pain is occurring in chest region, we're bound to want to rule out terrible conditions like myocardial infarction, which is heart attack, pericarditis, myocarditis, lung-related problems. No, we just do gamut of investigations. The results will be back. Nothing significant. All negative. If it's localized to abdominopelvic region, we'll be ruling out peptic ulcer disease, diverticulitis, appendicitis, no biliary colic, no renal colic, nephrolithiasis, ectopic pregnancy if she's a woman. Imagine the level of investigations that will be done, only because we've not taken history of chickenpox in this woman, and we are not faulting anyone. When anyone is having pain in this region, we have to rule out, all these terrible conditions. Now, if we are fortunate enough to have rashes later, good. But sometimes we don't. So days after, what I was trying to say is days after the woman or man had presented with localized dermatoma pain, then we'll pick rashes, erythematous, papular, vesicular, bullous, pustular. Sometimes we may never see any of this. So if no rashes at all, then we're dealing with another entity entirely. This is known as zoster sign hepatic. This is for another day. Now, how can we make a definitive diagnosis of pre-hepatic neuralgia? Let's pause, rewind back to the clinical presentation. We will do physical examination and then do serology. IgM will tell us if this is a fresh varicella zoster virus infection. IgG will point to a long-standing condition. We can have biopsy, but not commonly done. It's rare. If we are able to pick vesicles, we can swab the blisters for polymerase chain reaction. Either vesicles or pustules, just have swapped for polymerase chain reaction to get definitive diagnosis of varicella zoster virus, herpes zoster virus. Once the diagnosis has been accurately made, treatment is easier. Analgesics, antiviral agents. Other agents, depending on what is available in your country or jurisdiction, could be corticosteroids, gabapentin, oxycodone, and so on. The question is, why this presentation again? And my answer is simple. Because we do make wrong diagnosis when it comes to pre-hepatic neuralgia. And we just have to remind ourselves, the patient is presenting with a localized pain. Before running into so many different investigations, why not the history of chickenpox in the past, so that we can add the appropriate investigations that will point to varicella zoster virus infection on top of whatever we're thinking. That will save us from time and money wastage, because the patient will continue to suffer. Yet, all investigations have been done, or possible investigations done, CT scan, chest x-ray, serological investigations, so long, everything, blah, 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 cardiac enzymes, all coming back negative. Or haven't you had situations where patient will say they did everything, they found nothing wrong with me, yet my pain has persisted? It might be pre-hepatic neuralgia, and we will not get resolution until it is done rightly. Let's do just one thing. Let's take the pain to ask about the past history of chickenpox. Once that is taken, in anyone with localized pain, that will help us greatly. With the positive history of chickenpox, we can start thinking of pre-hepatic neuralgia, and that will help us as per the appropriate investigations that we can do quickly before wasting the time and money on big investigations. Then the patient could be out of the trouble, we can be happy, and the patient will be happy as well. With that, I've come to the end of this presentation as per pre-hepatic neuralgia. Just simple question. As per past history of chickenpox, will solve the puzzle, and the patient will waste less money and time, and will get definitive diagnosis. Please share with all your friends. Okay, we've just gone through the situation where there could be pain, and later on the rash will appear. What if there's pain and we will never see rash? Yet, we are still dealing with shingles. That is called zoster sign herpes. Let's go. Internal shingles. We're all familiar with shingles, right? That is when we see the rashes, the fever, malaise, headache, the pain, and so on. But sometimes, not everything will present that way. We might not see rashes at all, yet having pain, and it is shingles. In that case, it is internal shingles, otherwise known as zoster sign herpes, presenting with pain for months and even years without appropriate or accurate diagnosis. By way of definition of zoster sign herpes, it's better we find out some facts. Chickenpox is very common, we're all familiar with that, caused by varicella zoster virus. After disappearance of The rashes, fever gone, no more headache, no more pain. For years, it will undergo latency, hiding somewhere, ganglia. But reactivation is possible later in life due to many factors, including immune suppression, other diseases, medications, diet, stress, and the list goes on. And then we'll be faced with shingles when we could see the futures. But it is reactivated, we cannot find rashes, there is pain that is localized, then it's still shingles. In that case, it is Shingles A-Z. The clinical features will be that will be neuropathic pain that will be localized either to a dermatome or a nerve root, but no rash. The pain can last for months or even years. The pain here will last more than the typical shingles where we can see rashes. The true relief will be antiviral agents. If we miss the diagnosis of Shingles A-Z, the pain will be unresolved. There can be stroke, cerebral ataxia, meningoencephalitis, myelitis, Bell's palsy, Ramsay-Hunt syndrome, polyneuritis cranialis, where so many cranial nerves could be involved, but would not be involving spinal cord at that moment. How can we make accurate diagnosis here? Thorough history that will include history of chickenpox in the past. Then physical examination to be sure this is dermatoma or radicular, the pain. Then let's think of lumbar puncture. Rule out all contraindications to lumbar puncture. Obtain CSF for polymerase chain reaction or enzyme-linked immunosorbent assay, looking for the DNA of varicella zoster virus. We can have blood sample taken, going for the white blood cells, the monocytes, mononuclear cells, for DNA of the virus. We can have the serum for serology, going for antibodies, IgG for long-standing, IgM for recent infection. When that is done and accurate diagnosis has been made, then we are out of the wood. Analgesics, antiviral agent, and that will end the months or years of pain without accurate diagnosis. Less money will be wasted on big investigations. Just the history of chickenpox. And knowing that the fact that we've not seen rashes has not ruled out shingles. Shingles could be internal and damaging the system more and more. And once we're able to get accurate diagnosis, antiviral agents will solve the puzzle. Thanks for listening. Please remember to share. Now, the clinical presentations of shingles. At the early parts, it will be localized. Pain that we shoot, itching, tingling sensation, numbness, and there will be associated non-specific symptoms of fever, chills, headache, decreased appetite, nausea. Still on non-specific symptoms, vomiting, diarrhea, insomnia, malaise, lethargy. I call all those non-specific symptoms because so many conditions can give us that. The prodromal phase could affect about 75% of individuals with shingles, and that will be associated with pain before rash. That could be localized to a dermatome or a region, but it may cross the midline in disseminated shingles. In this case, it could be intermittent or constant, lasting about 3 or more days. Then the rash will appear after the pain. Here, wrong diagnosis is a possibility, and we're not faulting anyone. Some, if it's affecting the chest region, we could call it angina, renal colic, diverticulitis, appendicitis, as the case might be, depending on the region affected. I mean, where the localized pain is, or the region or the dermatome. Still on clinical feature, the ethical presentation could be sister sign hepatic. I'm not going to waste your time here because I have presented a separate full presentation on that. You can just pause and rewind. Okay. Now the pain could be pre-hepatic neuralgia. I have a separate presentation of that also already gone through, so you can pause and rewind. It could be post-hepatic neuralgia. Don't worry, in a bit I'll get to that. So the pain could be burning in characteristics, or throbbing, or stabbing, and associated with numbness, itching, allodynia, dysesthesias, localized to a dermatome, but could could affect more than one dermatome in disseminated shingles and could cross the midline. More in individuals with decreased immunity, so they are likely going to have more pain. Vaccination or high immunity will help, will lessen the severity of the pain. Activities of daily living will be affected, and the older you are, the more the likelihood of the pain. Now the rash. This rash should be painful and itchy and localized to a particular dermatome, but may be found in more than one dermatome in disseminated shingles, particularly in severely immunocompromised individuals. It's likely going to be more on the face, affecting the ophthalmic branch of trigeminal nerve. And if that is the case, the complication of blindness is imminent. Also found at the trunk, otherwise known as torso, and that would be thoracic and lumbar regions. The rash may cross the midline if Varicella zoster virus spreads away from the main dermatome. Shingles could be scattered later in life. It could be disseminated, usually limited to the corresponding ganglia single dermatome, but could be disseminated and cross the midline in severely immunocompromised individuals. Still on the rash. Now, the presentation will be initially erythematous purples. Then, a few days later, vesicles could be found, and that is the infectious stage. Later on, the vesicles are in grooves called bulli, and days like 3 to 4 days, pores could be found leading to pustula, but it could be hemorrhagic in immunocompromised individuals. At the 8th up to 10, the crust could be found. Then it will be no longer infectious. Many months or years after the resolution of the rash, there could be hypopigmented or hyperpigmented scars. Then, herpes zoster ophthalmicus or keratitis will be the diagnosis if ophthalmic branch of the trigeminal nerve is affected, leading to the possibility of blindness. Possible complications of shingles will include post-hepatic neuralgia, photophobia, blindness. In the case of herpes zoster ophthalmicus or keratitis, if ophthalmic branch of trigeminal nerve is affected. Other possible complications will include secondary bacterial infection leading to pneumonia, deafness, encephalitis, stroke, cerebellar ataxia, aseptic meningitis, myelitis of the pulse. But let me say that aseptic meningitis will be found in immunocompetent individuals. Other possible complications could include vertigo, Ramsay-Hunt syndrome, polyneuritis cranialis, or the end of life. Now, let's touch on diagnosis. To make accurate diagnosis, we need history and physical examination. When thorough history, like history of chickenpox and conditions that could lead to reactivation in this individual had been examined, then we can clinically make the diagnosis in typical cases. The history of rash, the pain, together will help us with shingles today. The individual could be immunocompetent, and in that case it will be localized to a dermatome or a region, and it will be unilateral, because disseminated shingles is now found in immunocompetent people, and disseminated shingles could be more than one dermatome and could cross the midline. So clinically diagnosed in typical conditions. In atypical condition where the history physical examination is not leading us directly, that may be because we are confused or the individual is immunocompromised, we just head to the lab. For what? Polymerase chain reaction, that would be the best. Enzyme-linked immunosorbent assay, direct fluorescent antibody, viral culture. Can even have serology IgG, IgM to know whether it's long-standing or new condition. Other tests could be done based on the complication or complications, like when the ophthalmic branch of trigeminal nerve is involved. We know who to call upon. Now, let's consider post-hepatic neuralgia. Post-hepatic neuralgia, shingles complication. Let's take the first note. Separate presentation on shingles will be out very soon. Here, someone would have developed chickenpox in the past with varicella zoster virus, got treated with antiviral agents, analgesic steroids, and the like. Then the virus will undergo latency. The virus will go and hide in the neurons of the cranial or dorsal root ganglia, and that will be as long as we live, lifelong. But certain things will happen. You increase in age, or immunity is depressed, and there'll be reactivation. Shingles with herpes zoster virus will have features that will include rash, pain, fever, headache, malaise, and so on. The pain will be from neuronal damage. Then, after the treatment of shingles, we'll still be battling with complications. And the most common complication is post-hepatic neuralgia, which is a profound pain lasting at least 90 days after the onset of rash. Post-hepatic neuralgia will occur in 12 to 20% of everyone who will develop shingles. The older we become with shingles, the higher the probability of post-herpetic neuralgia. In post-herpetic neuralgia, which is the most common complication of shingles, pain here will remain after the rash would have disappeared, and that pain will last for the minimum period of 3 months. Hence, the name post-herpetic neuralgia after the herpes zoster virus appearance and the rash has disappeared, then the pain will persist. The incidence of this condition will increase as we get older. Unfortunately, there is no cure, but it could be ameliorated. Let's go through the clinical features again. Shingles was in this man or woman before with rash, pain, fever, malaise, and so on. But rash gone now. The pain of post-herpetic neuralgia will be localized to the previous rash region. The characteristics will include burning, sharp, jabbing, aching, electric shock-like. There might be allodynia, meaning the individual will be sensitive to pain from a stimulus that ought not to cause pain at all, like feather or just a piece of cloth. There may be aparalgesia, in which case there is a painful stimulus, but the response to the stimulus will be beyond expectation, meaning exaggerated response. The duration of this condition is long. It could take months or even years. There will be acute photophobia. They don't want to see light. There can be numbness or itching. Some will find it difficult to sleep, insomnia, depression, anhedonia, meaning they are no longer interested in what usually gives them pleasure, like vacationing, camping, and so on. Even the diet could change, meaning they will eat less or no interest in eating. How can we make diagnosis here? I will not waste your time. There will be full info on shingles. There, I will go into details as per swabbing, taking samples from vesicles, polymerase chain reaction, enzyme-linked immunosorbent assay, serology, and so on. But for post-herpetic neuralgia, pretty easy. The history of chickenpox is there, that this person had chickenpox in the past, and after some years, shingles has emerged, and we could see the spread along a particular dermatome or along a particular root of the nerve. We'll do the physical examination to pinpoint where the pain is. Remember, no more rash. What are the possible risk factors here? Age. Age. That is the most important risk factor when it comes to shingles and post-herpetic neuralgia. The older we are, the more the likelihood. No past shingles vaccination could make it worse or let it occur faster. I'm not saying that with shingles vaccination you cannot have it. No, I'm not saying that. But it can delay it and reduce the severity. In fact, that is accountable for the reason why many people who had received vaccination in the past will not develop shingles on time. The site where the shingles occur is another factor. For example, it is worse to have post-herpetic neuralgia if it is located in head and neck region. The severity of shingles will also dictate how horrible the post-herpetic neuralgia might be. Like moderate to severe shingles will likely give us more trouble than mild shingles. The time interval between the onset of rash in shingles and the treatment will also be another factor. For example, if we'll start treating shingles within the first 72 hours of the onset of the visible rash or definitive diagnosis, the probability and severity of having post-herpetic neuralgia will decrease. Still on risk factors, the main issue besides the age is immunity. Anything that brings down the immunity will give us the chance of having shingles. For example, autoimmune conditions, and the individual is now having shingles. Remember, why treating autoimmune conditions will give immune suppressants. Then we are suppressing immunity. Someone with HIV or tuberculosis will be battling with cellular immunity depreciation, then giving rise to reactivation of Zika virus, giving us shingles. Someone is having diabetes mellitus. Remember, diabetes mellitus on its own can suppress immunity. On top of that, on its own, diabetes mellitus can give neuropathy. Now, someone with low immunity due to diabetes mellitus having shingles is now having another neuropathy known as post-herpetic neuralgia. Cancer and the cancer treatment with chemotherapy or bone marrow transplantation will all lead to decreased immunity and increase the chances of shingles with their severe complication. Now, post-herpetic neuralgia being the most common one. Still on risk factors, I'm back. Immunity again. Why that? Age and immunity will determine whether we have shingles, and the severity of the same that will determine post-herpetic neuralgia and the trouble afterwards. Now, someone is on steroid or on disease-modifying anti-rheumatic drugs, or someone had undergone transplantation and now on immune suppressants to prevent rejection. All these, including stress in life or chronic diseases like chronic kidney disease and so on, will decrease the immunity and increase the chance of coming down with shingles and post-herpetic neuralgia. Still on risk factors is more in older females than older males, and more in whites than others. Prevention. Prevention, they say, is cheaper than cure. Is there no way out? There's a way out. How? Okay, vaccination. Shingles vaccine is very helpful to prevent shingles, not to prevent chickenpox. So, in anyone 50 and older, it is better to have shingles. If you are 18, but you are immunocompromised, with the probability of running into shingles and later on having post-herpetic neuralgia, be vaccinated as well. Even if you have been exposed to chickenpox in the past, don't think you are immune for life. No, have shingles. It's just 2 doses that will be at 2 to 6 months apart. But contact your physician or pharmacist before vaccination. Now, treatment. Unfortunately, there's no cure, but the condition could be ameliorated, like I stated earlier. We will be using multiple medications here. We will start with lidocaine patch or capsaicin patch. Then, if we are not winning, we'll continue by adding anticonvulsants like gabapentin, that is Neurontin, or Lyrica. Antidepressant like tricyclic antidepressant amitriptyline. In elderly, let's go for nortriptyline, melamfacine, duloxetine, or whatever is approved for the use of these in your jurisdiction. If we are not winning, we'll move a step further. I don't want to get into opioids, but we cannot allow that man or woman to be suffering. We'll go for oxycodone or tramadol. If we are still not winning, we can go for steroid. You could see this. We're going to inject this through intrathecal route. Finally, there is room for referral to pain experts, neurologists, psychiatrists, psychologists as you deem fit. With that, I come to the end of this short presentation on post-herpetic neuralgia. It is the most common complication of shingles. Thanks for listening. Please share this with all your friends on your platform. I appreciate it. The treatment. Please, there's no need wasting your time. Kindly review all that I've said as per the treatment of pre-herpetic neuralgia and post-herpetic neuralgia. You can have a recap here as per the treatment. Analgesic, topical, and systemic will be helpful. We have to use antiviral agents. Azaclovir, ganciclovir, valsarclovir. Then we can add anticonvulsants or antidepressants like venlafaxine, duloxetine, tricyclic antidepressants in form of amitriptyline. But in elderly, I would rather suggest we go for nortriptyline. You can have steroids given intrathecally, and then handle depression and anxiety as may be appropriate. Job-related issues, because when prescription is given that affected individuals should be isolated, then social worker services will be required. Then we have to address specific complication or complications as it is appropriate. Then referral is welcome to infectious disease expert, pain expert, neurologist, psychiatrist, or psychologist. In conclusion, shingles may cross midline, can affect more than one dermatome, and complications could be more severe, or in immunocompromised individuals. Immunocompetent people can also have chickenpox, and shingles also can come down with all the complications. But with the help of vaccination and strong immunity, the severity will be lesser, and the time of onset will be later in life. Either pre-herpetic neuralgia or success-sign herpetic or full-blown shingles or post-herpetic neuralgia, we need antiviral agents. Thanks for listening. Please remember to share this, that without chickenpox, you cannot have shingles. But you can have chickenpox and not have shingles. Remember to subscribe to my channel. I appreciate it.